Good morning. My task is been rendered a lot easier by having Professor Neil Kay give his talk ahead of me because he has set the background, and all of the colleagues in the audience who have been treating chronic lymphocytic leukemia in the past few years, I would say 5-6 years, have obviously had an opportunity of using these two new drugs that Neil just alluded to. The first is inhibitor of PI3 kinase or Idelalisib, and the second is inhibitor of Bruton tyrosine kinase or Ibrutinib. These are my disclosures. So I will spend approximately half of my time on each one of these two topics. Upon discussing with the Dr. Furman, he felt that I should concentrate on use of these two drugs in some combination and demonstrating whether used singly is it less effective than when used in combination. And that's what I will do. And both of these studies that I'm presenting are different from the studies that the respective pharmaceutical companies embarked upon with a single agent and demonstrating to the US FDA that these drugs are uniquely effective. So what I'm doing is concentrating, limiting only to phase 3 trials, both in previously treated, relapsed, and refractory CLL patients. Starting with the Idelalisib, the PI3 kinase inhibitor. In this randomized trial, the effort was that if Idelalisib is combined with Ofatumumab, which is a CD20 monoclonal antibody, many in the audience have used it after having used Rituximab and before getting to Obinutuzumab. So Ofatumumab has been demonstrated to have single agent significant activity in previously treated CLL, and that used as single agent or used in combination with Idelalisib. The primary endpoint of this large randomized trial was progression-free survival. And in the curve that you have in front of you, it is obvious that the one on the top is significantly or visibly superior to the other curve. And the other curve is Ofatumumab alone, and the higher curve is Ofa plus Idelalisib. It's a clear-cut superiority of the combination, and the secondary endpoint was overall remission. There is hardly any complete remission even with the combination, because these are bad prognosis patients. But to have such a sizable proportion of patients having partial remission is in itself a major achievement, and there is no question that Idelalisib plus Ofatumumab is a powerful salvage therapy for relapsed and refractory CLL. The toxicities, and Dr. K already alluded to. Before I go to toxicity, another important observation, and that is that just as in the BTK inhibitor, there was a significant activity against 17p deletion CLL, Idelalisib plus Ofatumumab also had impressive activity against 17p. And as you are aware of, that until these two drugs came into clinical practice, we had nothing to offer for 17p deletion CLL patients. And therefore, in my view, demonstration that Idelalisib plus Ofatumumab can have a high proportion of partial remissions, which also are long-lasting remissions, is a major step forward. I seem to have been stuck. Here. The toxicities in the laboratory areas, both Ofatumumab alone and Ofa plus Idelalisib, had the usual expected cytopenias, and if I want to, and the other toxicities that Neil had mentioned were confirmed by this combination trial, that after several months of Idelalisib, there was a proportion of patients with the grade 3 or 4 diarrhea, colitis, biopsy-proven colitis, but fortunately not terribly large proportion. Something about this. Can you check why is my slide changer not changing, please? So this is a conclusion slide of superiority of Idela plus Ofa. It's really not working. If you can move for me for the rest of this presentation, I'll greatly appreciate. Is somebody up there to listen? Yeah. Next slide, please. Good. Okay. I apologize that something happened here. In any case, go back, please. Okay. So the next, as I mentioned, Ibrutinib plus bendamustine rituximab versus Benda Rituximab. BR, as we all know, after FCR, is a well-accepted, effective chemoimmunotherapy for CLL. And in this particular trial, Ibrutinib was combined with BR and compared by random comparison with the BR alone. Next slide, please. The study design was quite clear-cut, that by randomization, Ibrutinib or a placebo were used with BR. Next, please. And the primary objective was demonstration of superiority of progression-free survivorship when the combination was used, and indeed that objective was readily made. These are large sample size randomized clinical trials and demonstrate that the combination is impressively superior to BR alone. Next slide, please. The remission rate, again, as in Idelalisib plus OFA trial, in use of BR plus Ibrutinib, the overall remission rate was significantly higher than BR alone. And the 4 vertical columns are 2 for independent review committee data and the investigator read data. And there is no question that both of them had significant improvement. Next slide. Overall survival was significantly better in combination, but more important was that the minimum residual disease status was achieved in a significant minority of the combination arm, which is quite extraordinary and gives us great degree of encouragement that combination of Ibrutinib with chemoimmunotherapy in relapsed refractory is a major achievement. Next slide, please. Adverse events were somewhat expected, slightly more than BR alone, but nonetheless, grade 3 and 4 toxicities were not, they were greater in BR plus Ibrutinib, but tolerable overall. Next slide, please. Other safety observations were similarly tolerable, but clearly more significant in the combination arm. Next, please. In conclusion, Ibrutinib plus bendamustine rituximab emerged as a significant improvement over bendamustine rituximab alone in relapsed refractory patients. And I want to thank Maureen Joyce for helping me in putting together these slides. And the data that I have presented were presented by Jeff Jones at ASCO 2015 and by Asher Shanan Khan at ASCO 2015. So I'm most grateful to all the participants in those 2 large randomized phase 3 trials. Thank you.